that if you go through the arteries, chances of creating ischemia is very often much higher than if you go through the vein. And look at this AVM. This is a small AVM which just bled. That's why the arteries are, the normal anatomy is somehow modified. And this AVM is something which is reasonable to treat. Definitely just bled, you need to cure it. The only problem is that this AVM is located in the central sulcus. So those arteries are highly functional. And if you look into the selective injections, you see here that you feel the AVM, but you feel also a normal artery here that you can see on the lateral view there. And if you look at the other feeder also goes to normal cortex in a high functional territory with here some en passant feeders, but it all goes to that vein. And how can you embolize this AVM while keeping this artery, and that goes the one back, this artery both patent? And this seems very difficult from point of view of artery. But if you consider this vein, of course, it's here a bit more tricky to access to the vein, mainly because of the junction between the vein and the sinus. And this requires very often a lot of efforts to be able to cannulate the vein. So this is not so easy, but once you're inside, and once you reach this point here, which we're about to do now, first, I put some coils to obtain some thrombosis of the vein. And now you can see during injection of onyx, this is regular onyx, I can accelerate a bit. And you see that the whole AVM is being filled. And finally, the duration of injection here is 40 seconds. And within 40 seconds, you occlude all arteries. And you see that the AVM is gone and the arteries are spared. So these are here, of course, striking examples I chose that show that if you would have gone through the arteries, some brain would have certainly been damaged. Look at this, another example. That's a very small AVM, but it bled in the brainstem, in the mesencephalon, and the AVM is hardly visible. Maybe you can see the vein here, which should not be there. Now you can see it better, okay? This is the outflow vein of this micro AVM, which you can see here. This is the outflow vein. And if you want to get there, very often, this kind of AVM supply comes from a little artery, which is here, located at the origin of the P1 segment, at the origin of the PCA, so lateral artery, which you can cannulate. So here the magic is being placed just before the artery, and you should be AVM soon. Then what we do now, there's a good reason for this. And the reason is, if you look at the further angiographic image, it's this one here. And here you see again the artery, the vein, but you see this also. And this is a highly functional artery getting to the mesencephalon. And if you would have destroyed this artery, the patient would have been functionally impaired, significantly impaired. So that's why here I chose to go to the vein retrogradely. This was tight, this was really tough. But once I place a catheter here, here is a sonic microcatheter, catheter with a detachable tip. Here's the magic in the artery. This is injection of a couple of drops of onyx through the magic, and then through the sonics, and the sonic was withdrawn, so it's a venous injection. And look, after this injection, the appearance through the artery, you see that this functional artery that we wanted to keep was maintained. So definitely, those are examples where you see that the advantage of getting through the vein is either to be able to cure the malformation or because the vein is more easy. But in the last two examples, it was the only way to avoid destroying normal brain. Here's another posterior fossa AVM, quite large. So I did 3 transaterial embolization to reduce it. And now it's significantly reduced. Now I did another transvenous, taking this vein here. This is after the first transvenous embolization, and this is what remains. So you're almost at the point that the AVM is going to be occluded. But we wonder, should we go through the artery? Should we go through the vein? It's difficult to know. So we put a catheter in the MAGIC in the pica. And here's a MAGIC in the pica. Here you see the vein on the lateral view, on the AP view. Here is the MAGIC, the distal tip of the MAGIC. All these are shunts. But this here is brain. And if we would embolize from the artery, we would occlude the shunts, but we would also induce an ischemia at this level. And this is why I prefer to go through the vein, occluding this here from the vein. And you see after embolization that all the brain has been spared. So another example that shows that the ability to damage less brain is significantly higher when using the vein than using the artery. So hold on. Let's do something else now, which is let's go in an AVM where we can do both. We can use the vein and we can use the artery. So this is frontal AVM. So I reduce after 2 steps to this. And now here, I don't know. What is better? Is artery better or is vein better? And here is a magnified view of the branches of the pericallus, those feeders, which around the question is, should we go through the vein or should we go through the artery? In case of doubt, I did both. I put the catheter in the vein and then I put a catheter in the artery. And then I said, we're going to see which one does more. So here is a catheter in the artery, where at this level, we see those arteries arriving here, starting to give the vein. And here we see the vein up to this point. So this is a catheter in the artery. This is a catheter in the vein. These are the locations that could be obtained. And in both situations, I use a pressure cooker in the artery and in the vein. So this is injection from the artery, where you see that it goes down, still no reflux. It continues to go all along the course of the arteries, expecting that at some point it will be possible to reach the primary veins. And it's getting a bit larger, so maybe we're not too far away. This is further arterial injection, same position of the catheter. And you expect this to continue, but it accelerates a bit. It continues somehow, but not only, you have also some further arteries and some reflux here that are filled. And then when I wanted to maintain arterial, then we just had reflux and something here that was filled far away from the shunts. So at this point, after trying from the artery on and on, I decided to go through the vein. And this is injection from the vein, where you see that you inject already retrogradely from the vein to the arteries. And I continue progressively here. It starts to go to the vein, to the main vein, but simultaneously back in the vein and in other arteries. This is, here's the view. Here you have the vein, which is done, and it goes simultaneously in the vein and back in the other arteries. And I think this will be the last injection from the vein, where you will see that from here, access, which is the case here. Here you just could see the course of an artery. This is an artery here that was joining the vein here. It's interesting to see that if you look the videos on and on, you will rapidly have a quite clear understanding of what is artery and what is vein. So in this patient, obviously, the better way to occlude all the shunts was the vein and not the artery. Another thing that I've been finding when using increasingly transvenous embolization is that you just consider the vein as a potential further access to the AVM, just as you have arteries that are potential feeders, then you consider the vein as a potential feeder too, and it completely changes the way to treat AVMs. And we go first this example of this anterior temporal left-sided AVM, where you have here the angio. We can do it again. Here is the angio, and it's not such a difficult AVM. The AVM is quite small, so the chance to cure it is quite high. However, if you look at the vein, this outflow vein here, it becomes very narrowed here. There is always a stenosis at the junction between a cortical vein and the sinus. And this stenosis is potentially a problem because if you lose some embolic agent from the artery and that this then the whole AVM might bleed. It was the reason in this patient why I changed strategy. And I thought if I'm gonna take just any liquid embolic and some liquid embolic is going to block here, maybe you can see it on this picture where the stenosis is on the vein. Maybe there's another picture where you can see it better. Then I was afraid of having the AVM bleeding. So here is a rotational angiogram, or maybe if we take the rotational angiogram, we can see what's going on. Maybe you can see the stenosis here. It's somehow visible. Otherwise, you must believe me, between this cortical vein and the sinus, here it was very narrow. So I chose first to access to the AVM with the usual magic and to an efficient way, which is to use flow coils. You know, the coils that were developed by Alex Bernstein, the Bernstein liquid coils. I asked Bart to do the production and inject those coils. And those coils, here you see that one is injected through the feeder. And interestingly, maybe you saw this picture. I go a little bit back. This is the artery. And you see that there's a side hole there where the coil goes from the artery to the vein. Very interesting to understand how the angle architecture is here, because this was not presumable. And I continued to get access to most of the arteries here. This was coiled. You see those coils here that are those coils. These are in the artery. This one is in the vein. But before coiling the artery, I first placed 2 microcatheters in the vein. So 2 catheters in the vein. Then I start to coil the arteries. Here is another feeder, which is a very simple feeder where some coils can be injected and placed. And then once all arteries were coiled, I coiled also the vein. So I did not touch the so-called Nidus, but just blocked all arteries and all veins. And when all arteries and all veins were blocked, this was the angiogram. And this is a very unusual appearance, because if you look at this here, you don't see the AVM anymore. Of course, it will not stay like this. of course, it's unstable and dangerous, but the arteries have been occluded and the vein has been occluded too. So I would say now the AVM is not killed, but it's paralyzed. There is no flow inside the AVM. And if there's no flow inside the AVM, as a catheter is inside, a kind of Trojan horse technique, the catheter is in the AVM is not moving. So now it becomes very simple to inject any liquid embolic. This is injection of a liquid embolic inside the AVM. You see here it's a 1 minute injection of this. And then this is a 1 ml of onyx. And this is another ml of onyx, another injection throughout the AVM. What you can see here. And with both syringes of onyx, the AVM could be completely occluded and was cured in 1 step. Here you see now the AVM is occluded, the arteries are proximally done, the vein is done, and inside the shunts are occluded too. And this you can only do because you consider the transvenous embolization as a possible technique. Here is another example of this AVM located behind the insula, I would say at the level of the operculum. No, it's insula. Here is a venous aneurysm. Here is the outflow vein. I hope internet is okay. Yes, here's the outflow vein. And if you look more with zoom, you can see here that here's one feeder, a posterior feeder and an anterior feeder. And before starting to treat the AVM, you must first take a magic and look at all the arteries surrounding the AVM to be sure which one are giving the AVM, which one are not. So here is the posterior, here is the anterior feeder. And from there, the posterior feeder, I did not want to embolize because I could see normal branches coming out of them that I wanted to spare. The anterior feeder was just getting to the AVM. So I put coils in the anterior feeder. Then I could use the same microcatheter, go to the posterior, where I did not put any coils. And then I coiled the vein. But to coil the vein, you need to bring the patient under low hypotension. And of course, coiling the vein means you coil here, but before you place a catheter, which is at the very origin of the coils, so that you don't need to cross the coils with the onyx, but you keep the tip of, do we see it here? Maybe we can see it, not sure. At least the microcatheter is being kept inside the vein more distally. And now that the vein has been coiled and the outflow is out, you see that the flow is almost completely gone inside the AVM. Still, the AVM is not done. You still have shunts. You still can see the primary veins. But under hypotension, as you've got a catheter which is inside the vein, you can inject inside the AVM. And you can see that you have here some retrograde filling of arteries. So take care. If you inject in the vein, at some point, you will go from the vein to the artery. Simultaneously, as when you're in the artery, what you inject will go from the artery to the vein. Here you can go from the vein to the arteries, and you keep on. And you see once the AVM is done, this is the arteries that I did not want to embolize. Both arteries here are kept patent, and the AVM is curable. And this kind of approach to say, I put a catheter inside the AVM in the vein and then coil all arteries and all veins is something which is also a completely different approach to what we've been doing up to now, but which is possible because you take control of all feeders. So of course you cannot do this in all AVMs. It must be restricted to small AVMs where you are sure to control all arteries and all the veins, but that's the case here. And this is another point that we learned. We've been doing now a little over 300 transvenous embolization. And for me, I was sure that as soon as I would occlude the vein, the AVM was going to burst and to bleed. This is what I learned from neurosurgery. that when the vein is clipped, then the AVM immediately starts to bleed. And interestingly, the answer is no. If the patient is under hypotension, which means systolic is about 60, so it's a strong hypotension, then the AVM will not bleed. You've got some time. If there's a craniotomy, everything is open, then the patient and the AVM may bleed. But like this, is not a bomb, not immediately. You have, I don't know how long you have, because I still have not experienced it, and I hope that I will never experience, but up to now, I've been seeing that you have more than 10, 15 minutes before you can embolize, definitely. So, transvenous versus transarterial. Sometimes you got a better access to the shunts. You often have less ischemia by transvenous and because of the ability of transvenous, you must change the rules of the game and the way you proceed. To control the amount of reflux is what I call the retrograde pressure cooker. And I think that this is something which is quite important, because the main problem with transvenous embolization is that you cannot just stop because you don't understand anymore. This is something that is done on a usual way when embolizing through the arteries. And at some point, if it starts to be close to the vein or not, safety is to stop. If you go through the vein, you cannot stop. It is not safe to stop. You have to continue. And here is a drawing of what I believe how a nidus looks like. For me, there's no nidus. There's a venous segmentation where you have primary veins that join together in the main vein. And to make a pressure cooker means that you need two catheters in order to build a plug. But while you deliver the coils, the catheter goes back. And this way, then you start to inject onyx, but onyx will go with the flow backwards. When onyx reaches the coils, at this point, you can start to inject histoacryl within the coils if the tip of the catheter is here, in order to control this vein, but not to occlude the whole vein. If you would occlude this vein here, this part of the AVM would bleed. So you need to have a control of each of the veins you want to treat, and this way you can continue and occlude all the part that you want. Where you decide whether you stop or you maintain embolization, but it is not a reflux. The reflux is something which is uncontrolled, which is not voluntary, and I strongly disagree with a statement that says you can occlude as much vein as you want. Nobody knows it. Nobody is aware how much vein you're allowed to occlude, or how much vein you're allowed to keep open. And this you only know once you've been occluding a segment of vein. When you do the MR and when you see some edema, it means that the segment of vein that you occluded is also responsible for the outflow of the brain. But controlling the amount of reflux is very important by considering venous approach. Other things that we've been noticing is that, when you do the retrograde pressure cooker, don't take diluted histoacryl. Diluted histoacryl may be pushed by the onyx. So it needs to be high concentrated histoacryl, something like 50% lipiodol, 50% histoacryl. Another point that I recommend, if possible, take detachable tip microcatheters, both for the onyx and for the histoacryl, so that you can keep the catheter in place and continue embolization. But in the end of the embolization, you take the catheters here is an example of what happens if you have a catheter which is not used for hysterocrine out. Is very often disrupts the cohesiveness of the hysterocrine, of the hysterocrine, and then if you continue, you may have some onyx getting through there to the rest of the vein. I hope that this is clear, that you can still listen to me. I'm not sure whether it works. Onyx is something which is also of help, which I recommend to do. So taking diluted onyx, this is why Squid 12 came on the market. Squid 12 has a reduced viscosity, and you can deliver more embolic agent inside the veins. Is it okay? Does the connection work? Could you please give me some back info?
No, it's okay. Yeah.
Okay, yes. I was not sure. That's why I wanted to ask. Okay, so let's continue. So Squid 12 is definitely the fact that it's less viscous enables to do more. And as I said previously, when you inject inside the vein, you're obliged to succeed. You cannot leave any part of the AVM occluded. That's why the fact to take reduced viscosity ethynyl vinyl alcohol enables to bring more embolic agent inside the AVM. Here's an example. This is a frontal AVM I treated, I think, at the beginning of the year, which I thought was going to be easy. It was not at all. It was much more difficult than expected because there was no good arterial access. And when I considered the vein here was very difficult to follow, very slow. Finally, I could see the vein here. So I could put a catheter in the vein using this rod. And here's a catheter in the vein using this rod. For the second, to do the pressure cooker, I used another vein. And here was a balloon in the artery. And when I started to do the venous embolization, I obtained this cast. And this cast, if you compare it to the AVM, it does not fit 1-to-1. You see? Here, at the anterior part, is something missing. Again, this is what was obtained at this part, at this level of embolization. Here is what is still open. So knowing this and having a very diluted onyx enabled to continue and to have those remaining shunts occluded up to this point where now the AVM is completely cured. So these are the factors that are important. If you don't have it available, there's a very easy way to clear it. Just add a couple of drops of DMSO inside your onyx. If you just inject 3 or 4 drops, you will reduce the viscosity and you will see the difference while you inject on your syringe that the force is lower. And the fact to have reduced viscosity reduces the risk of remaining shunts inside the AVM. But this reduces also the risk of hemorrhage, because hemorrhage is related to some shunts that you are not able to occlude despite the factor in the vein. Up to now, the risk of hemorrhage is low, but it's still present. I would prefer here to have 1%. I don't have 1%. My risk after 322 transvenous embolization is of 4.7%, and I do a lot of efforts. It's very you occlude all shunts and that you start to do a transvenous embolization. My advice, which I it's okay, we had a connection problem. I hope it works again. So if you can hear me,
yeah,
I continue.
now it's okay. Now it's okay.
Good.
Please.
So, and the fact to understand the anatomy of which helped me to enlarge indications from AVMs draining into a single vein, small AVMs draining into a single veins, to larger AVM, so that's treated step by step. So this is the first AVM I treated by the vein. It was in 2004. It's a patient that had many veins in the past. She had been treated 3 times by radiotherapy, and she had multiple embolization attempts. And none of them enabled to cure the AVM. And she came back with another bleeding, and you may see here that the veins absolutely are not accessible, whereas the vein is a very straightforward vein, even if there's an aneurysm here, which is certainly the cause of bleeding. So here's an example of a more difficult, more challenging AVMs. These are the kind of AVMs that are treated right now, where you may see here the different compartments from the anterior, from the ACA, whereas the AVM this is the first step, occlusion of the part from the ACA, then from the MCA, step 2, step 3 from the PCA. So a lot has been done, but it's still not finished. And you may see that here are some portions of the AVM that remain. And even if it's not much, the AVM is not cured. This 30-year-old man bled, and you need to cure him. And to obtain a cure, the best way here was to get access from this vein, getting to the lateral sinus, getting around the temporal lobe, joining the deep circulation. And this enabled here, this was one vein, this was a second vein. And once you've understood those veins, this is what we obtained by the first vein. And then only this part was remaining. And this is what we did in another step, getting retrograded to that vein here, occluding this, and then curing the AVM. And I must say that I'm surprised to see that today it's possible that those very large AVMs can be treated. And this patient, surprisingly, even does not have a hemianopsia. He's doing some car racing, he's a pilot, and he sent me recently some pictures where he was taking part to car racing without having hemianopsia. But the key point when you go into stage venous is to understand the venous segmentation. And to understand the venous segmentation, you must understand what is called the Nidus. But the Nidus, whenever you look at the different drawings, whether it's this drawing or this drawing here or this drawing there, those drawings all have one thing in common: they explain nothing. A drawing is supposed to explain to you how the vessels are connected, and in all those pictures, you never understand anything. You just see that something is blue, something is red, but how it is connected is not visible, simply because if you look at anatomy, you don't understand. If you look at angiography, you don't understand also. When AVM are treated by radiation therapy, connections are not understood, and when they're operated, it's always a block resection, but the neurosurgeon is not able to clearly define which vessel is connected to what, because otherwise he would have to cut inside the AVM and it would bleed. So I would say Nidus is the common characteristic of AVMs, but this word Nidus is a way to hide our ignorance. And when we do a partial embolization just on this picture, the fact to take part of the AVM does not enable to understand how the junctions, how the branches are connected there. So some things helped progressively to understand. One was an arterial pressure cooker, and this is a child treated some years ago with a venous aneurysm. Here was the microcatheter in the shunt. And what you can say here is that there is a macro shunt. Here is a large artery. Here is a vein. But it's impossible on this picture to understand anything. You cannot understand how arteries and veins are connected. Whereas when you do an arterial pressure cooker, which is create a plug with histoacryl and coils, then you may understand how the arteries here are connected to the vein. You can look at this on a magnified view. And if you look here, even able to follow each core, and you can make a very precise. And interestingly, when you look, I go now backwards, when you look how the AVM was to be understood without pressure cooking, nothing is to be understood. So you need to disrupt the flow, and once you disrupt the flow, you may be able to understand from the venous side. And probably this patient here was stem AVM, where the catheter, the feeder is coming from here, not the percheron artery. The percheron, this one is here, gives nothing. The feeder is coming from there. This is the feeder. And even if you make a selective injection, it's difficult to understand how the angio architecture is done. And even if you make a 3D picture, a rotation angiogram, you don't really understand how the shunts are made. I cannot say how it is. I've been looking at this picture very often and I can't understand. Now I put a catheter in the vein, which was definitely very tricky and painful because I had to go through the cavernous sinus. And this is the injection from the vein inside the AVM. And here you see the retrograde injection from the vein. And you see that whenever you maintain, you can see very well the segmentation. Here is a vein, and the primary vein. Here's another primary vein. Here's another primary vein. You can see the branches of your AVM very clear way. So that I would say an AVM, the scheme of the venous segmentation of an AVM is this, a main vein, several primary veins draining into this main vein. And then each vein becomes different arteries getting inside each of the veins. One artery may be larger. Sometimes we may have macro shunts, but this is a global scheme that we need to have in our mind to understand what an AVM is, that we can draw this way too. And once we agree on the fact that this is the core of an AVM, then we can treat other AVMs that cannot be treated by the arteries. This is the wife of a colleague. She has a deep ganglia AVM that bled 20 years ago, and she just rebled last year. And this is the anterior circulation. This is the posterior circulation. And by looking at those pictures, we know that it's very tough to reduce this AVM. It's probably not possible to cure it. And the risk, whatever we do, is very important because we may compromise the small feeders to very important area. But if we look at the precise angio architecture of the vein, if we look at the venous segmentaire, a third here, a fourth, and a fifth. And if we consider that those are the veins joining to the AVM, then we're able to treat first the vein. This is the first vein we occluded, selectively taking care not to compromise the other vein. And then this is the second vein we occluded in the second session here. And then once the whole anterior part was done, then we went to the posterior part. Maybe you can see here the difference in number 3. I took this vein here that enabled to occlude this. And for the last session, the last vein was occluded, enabling to cure this patient. Now she's cured and she's doing fine. Here's another patient, a 22-year-old man with a large insular AVM known since 15 years. And he got many embolization in very good and this did not prevent venous aneurysm to grow and to develop. Parallel, he developed a fluctuating hemiparesis. This is his AVM. This was in 2004. And then some years later, in 2008, arterial embolization, the AVM is still growing to this aneurysm that was not existing before, which is here, which is obviously a major threat. So treatment was first to go to arteries. This is a rotational angiogram showing the AVM. And after doing some arterial embolization, first arterial, second arterial, and then third arterial here. Some of the AVM was done. You see that the vein started to stagnate, so I had to give some anticoagulation, and now the vein has been reduced. And then at this point, I started to go venous aneurysm that reduced. This was only by transarterial. But getting through the vein, I first took this vein here to go through the aneurysm inside the AVM, finding first an arterial feeder, allowing to show this vein where you need to access to in order to get inside. This is where the shunts that were occluded. And you see that after this venous session, there was no deep vein. So we reduced the Spetzler-Martin grade here by 1 because of no deep vein anymore. And then the second vein to access to was this one here. So this was another step. Session number 4, transvenous embolization number 2. This is the artery that was injected. You see here the shunt. This is a venous navigation. And this here is a shunt from the vein. And here's the arteries. And then during Alice, we treated in November, taking this vein, occluding the parts. And then the remainder at this stage was this. And this is very interesting. Maybe you can look at this. This is why I put 2 pictures here. It's a selective arterial injection where you first see this vein here, and 2 seconds later you see this other vein. Agree? You first have a vein here, and then 2 seconds later you can see another vein. This enables to show that you have 2 different veins inside this AVM. First this one, second this one. So inferior vein, then into this vein, so putting 2 catheters, 1 in each part, in order to occlude first this compartment, second the other compartment, and this enabled to cure the AVM. And now this patient is doing really fine. He sent me some pictures where he's doing some skateboarding or something. I mean, he's really clinically normal. So understanding the venous segmentation, how to understand how those veins are connected. This is probably the key to avoid problems. Maybe you can see it on a global injection, but it's not easy. Probably the 3D imaging helps. And I will show this example where you may see that this AVM, which bled, it was treated already by Transaterial embolization, where you can define this vein, but it's difficult to understand the vein precisely. And when you look at the 3D imaging, you see the vein which is here, and here you see one vein arriving there, another vein here, and you see that the posterior vein has also two primary veins, and the more anterior veins here has this one and that one. Maybe you can see how those veins are connected. And this is the key point, to see how the different veins are connected. So again, here is the vein with one first vein, which is arising after junction of those veins, and another one here, which is also arising after junction of two veins. So to be sure to get all four veins, I put a catheter here, I put a second catheter there, and then I coiled all these Y parts, which you may see here. Here is one catheter placed, here's the other one. This was coiled through a third catheter. This is a retrograde injection, which enabled to have this AVM cured. And here's a 3 months follow-up, because a cure can never be said on the first control, but you always need some further follow-up. Okay, I will pass this. So which AVMs to treat? That's a difficult question, which answer is not so obvious. The more you do, and the more you enlarge your indications. But please don't misunderstand me. If you want to start transvenous embolization, take a small AVM, take a deep located AVM, because the deep veins through the straight sinus are better accessible than the veins that drain into the superior sagittal or lateral sinus. And progressively, the more you get confident, the more you can enlarge your indications. And this is a large frontal AVM, where after 5 Transaterial embolization, you could see that this is after 5 Transaterial embolizations. And finally, after transvenous embolization, a cure could be obtained. And this is a major evolution. Before doing transvenous, AVMs were reduced a lot, and then the rest had to be treated either by radiation therapy or by surgery. But we were very often unable to cure AVMs. And this we can do today by using the transvenous. Same thing here, horrible, very large AVM, left untreated for 20 years, and then she bled and re-bled. So we've been going through 5 Transaterial embolization, and then this was treated by transvenous in different steps, and now she's cured of this insular and opercular AVM, which was treated 1 Transaterial, 3 transvenous step, allowing a cure, something very similar here, also cured. Another very large one, where you see that it's extending along the whole corpus callosum, and treated many times, many embolization, some of those embolization, unfortunately, quite proximal. So because of this, a lot of anastomosis developed from the right side, also from the left MCU to the left arterial. So it's very long and painful, but possible to navigate with the smallest magics through the anastomosis, go back here, then you can occlude those arteries. And once this is done, you look at the vein. You may see those both primary veins arriving into the main vein. After occluding of most of the arteries, then I could go retrogradely inside. This is after arterial embolization. And then, and after arterial and then venous, occluding this one and occluding that one, enabling this AVM to be cured. Or also the very ugly location in the brainstem that you cannot do by arterial embolization, but by venous, that can be cured with some follow-up. Same thing here. where you see that after transvenous, even those terrible AVMs can be treated by functional territories. And probably the last one I will show, deep ganglia, huge AVM, bleeding repeatedly because of this venous aneurysm, where after transaterial embolization, you see that the posterior component is reduced, but my goal of reducing the venous aneurysm failed. I could not reduce it, so I had to go through, maybe you can see what is remaining is really very large and very ugly, with this large venous aneurysm. But after first transvenous and then second transvenous, you see that this patient could be cured, and shown images is of low significance. This is a patient 4 days after the second transvenous and the last embolization. He still has some left paralysis from his initial bleedings, but the patient is doing very fine. So as a conclusion, definitely transvenous embolization changes completely the game. And the combination of transarterial and transvenous enables to achieve cure of most AVMs. To achieve a transvenous, it's important to control the amount of venous reflux. Veins are functional too. You cannot just occlude veins and accept growing reflux. So the reflux must be controlled. Taking embolic agent with reduced viscosity is a way to reduce hemorrhagic problems, because you're able to inject more embolic and occlude more shunts. So drawback of this, if you inject more embolic and if you reach the arteries, then you increase the risk of having some ischemic complication. And I see that there is a progressive enlargement in my way to handle AVMs. And now even deep located AVMs and large AVMs can be treated using staged transvenous embolization, which means that you need to see if each vein is long enough to control its occlusion. But I would say today, most of the AVMs can be cured by embolization, and especially AVMs that are very difficult to be treated by radiosurgery or by surgery, can be treated and cured by embolization. And I think it's my last slide. Yes. Okay, so I should be done now.
I think transvenous and special technique is a game changer for AVM treatment. Here, I'd like to take the opportunity to introduce our great teacher, Professor Kanok Kanti Borua. He is Vice Chancellor of our Bangabandhu Sheikh Mujib Medical University. He was former professor and head of the Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University, and he was also president of our society. I'd like to request Professor Kanok Kanti Borua sir to have few words for us. Professor Kanok Kanti Borua sir, do you have? Are you there online? Thank you, sir, for your beautiful talks. So, I'd like to invite Dr. Shukarlan Purakas to have his comment and some discussion on Professor Rene's talk. Dr. Shukarlan Purakas.
Yeah, Dr. Shafiq, good evening. Can you hear me?
Yeah, sure.
Yeah. So, thanks, Dr. Rene, for your wonderful talk. So you made this whole lot of complex thing very, easy for us. But I can tell you that, your technique and the results are not easily reproducible. So you only can reproduce your result. So that is, I'm very sure about that, because in India, what we follow is it depends which center you are working. and how the things work, because because till now surgery is a very important modality of curing AVM, and the surgeons in most of the cases want to go for surgery maybe after embolization to reduce the lesion. In some cases where the radiosurgery is very strong, so in some of, and even we also follow that, we reduce the size of the AVM and then send for radiosurgery. Because in most of the centers, the interventional neuroradiology is very closely watched by the neurosurgery team. And if your the risk of treatment is a bit higher, then maybe you'll be questioned, because to achieve your expertise, you need to understand the thing properly. You need to have a large amount of transarterial embolization technique, and having expertise, getting expertise on this transarterial, probably you should venture on the transvenous technique. So having said that, because we have many young neurosurgeons and neurologists here who will be waiting to start these things, I have few basic questions for me to understand. Like, if you have a single artery and a single vein, maybe a cortically located AVM, which you think maybe both you can cure by both transarterial and transvenous, which route you will follow? That is my first question.
So please unmute yourself. Please unmute yourself.
Is it audible?
So you are muted, sir. Musan, unmute kar dao na.
Okay, that's a very good question. You're absolutely right. The answer is, I mean, there is no easy answer to this. I want to place the venous embolization that in your mind. Once you start to think about it, you will consider it each time, and you will start to struggle whether artery or vein should be better. Maybe the best answer to your question is, what is your rate of cure of the AVM if you go through the artery? In the situation you describe, it may be high, it's rarely 100%, because we all know that if you start to embolize, many things happen not necessarily as you expect them to occur.
Yes.
And this is very frustrating.
Absolutely.
But when this starts to occur this way, whenever you have the venous access, it enables you to do what you could not do from the artery. So for instance, one way to proceed would be to say, okay, I accept 2 more hours of effort to bring the catheter in the vein.
Yes.
I accept the increased cost of taking another catheter to bring inside the vein. So it's already a lot of things that you have to accept. But because of this, I have the safety that I will be able to cure my patients and not to come in a situation where you occluded most of it and you occlude the vein and it will be bleeding, which you want to avoid. So in fact, when you start to consider the vein, please don't consider it for all AVMs. It's a progressive process, but the more you consider that you could get through the vein, the more you think of it in each situation. And then you would have a situation where you almost succeeded by the artery, but you did not. And then you would say, if I would have put a catheter in the vein, probably I would have solved the problem. So next one you will do, you will have a catheter in the vein. This is the way I did it for me.
Absolutely.
And I think it's progressive evolution.
Absolutely. Yeah. So what we understood from your talk is that you said very specifically that you should start with the deep-seated AVM, where your access of the vein is quite straightforward. and the arterial feeders are quite difficult to cannulate, or maybe a lot of en-passant feeders, which is going to an eloquent cortex, where you are not very sure that by arterial embolization you'll be able to cure that for a small AVM. So those are the AVMs. Maybe you should try first with the venous access. Is that correct?
Absolutely. I think that it's a new tool. It's a tool that opens perspectives, but it's not something that must be used widely. And I already
Yes.
apologize for showing situations that where we unexpectedly obtain cure, because it's something which is a work in progress, and
Yes.
it's a great technique, but it can create also a great amount of problems. If the vein is compromised and the AVM is not cured, you can be sure that the patient will bleed. So you must be sure once you start to occlude the vein that you will obtain success. So the best patients are, to start with, the AVMs that are not too large, that are deep located, where surgery is dangerous, where radiation is also dangerous. Those patients that bleed are usually young patients. Radiation therapy in young patients has some long-time effects that is a concern too. And if you can, within one procedure, cure your patient, that's very good. But I see also in my department now the younger teams, some of the younger teams have been doing more transvenous than transarterial. Can you believe it?
Yes.
So I'm
Yes.
surprised to see that some persons in my team now change and do more venous than arterial. So in my practice, it's ongoing change, and I have no doubt it's going to be in your practice too.
Absolutely. Yeah. You are the one who taught to the whole world the transvenous way of embolization. So can you tell us for our young guys, what are the hardwares you use for the, catheterization of the veins? And here in Bangladesh and in India, we do not have the Bernstein coil. We had it quite long back, maybe 20 years back, but till now we do not have those flow coils. So we need to use the larger catheters, both in the artery, maybe vein, it's okay if it's not a tiny vein, but
That's a,
yeah, so
that's
your
a very
technique
good
of
point.
catheterization.
That's a very good point. The larger the vein, the easier you can cannulate, but the more shunts are to be occluded. So if it's too large, it's dangerous too.
Yeah.
Definitely microcasters like the Apollo enable some coils to be placed. Not all coils, so regular detachable coils usually don't fit, but some of them fit. There's 3 different companies. Some are the barricade coils from BALS, some are the ED coils from Japan, even some coils from Medtronic are also compatible with the Apollo. So
Okay.
that's a good catheter where you can put regular coils inside and it may help.
Correct. And regarding the technique of catheterization, because the veins are more mobile than the arteries, and it's more fragile than the arteries, especially those veins who are in the subpial location. So do you have any special, because you have shown like great tortuous veins which you have reached after a long way. Of course, it took a long time, but it takes a long patience and the masterly working technique of yours. So what is the way forward for our young guys?
I mean, the AVM located deeply are accessed via the straight sinus from the straight sinus to the great cerebral vein. The access is usually quite okay. The important difference between veins and arteries is that you cannot force. If you push and force, the veins moves more, doesn't offer enough support. So it's a constant game of equilibrium, pushing. But if you see that it does not happen, just taking back the force, and this way the catheter will be handled better than just giving more force. Another important detail, the guiding catheter should always be placed inside the straight sinus, because if you keep it more,
you prefer? Which guiding catheter you prefer?
any 7 guiding catheter, I enjoy the Fubuki 7 French, but any 7 French guiding catheter allows to be usually placed properly inside the straight sinus. If you keep the guiding below the torcular, then the microcatheter will make loops at the level of the torcular, which is an issue. So jugular puncture is definitely an important thing. It's really nothing to do a jugular puncture. It's more a question of that many physicians prefer to go on. It must be taken to puncture the jugular, because then you've got enough push to bring a guiding inside the straight sinus.
Fine. Yeah. And you have told you use around 50% of histoacryl to block to plug it while using the retrograde pressure cooker. Around 50% of histoacryl.
Yes, it's a 50% dilution histoacryl. So it's 50% lipiodol and 50% histoacryl. I hope connection is okay.
Yeah, we can hear you.
Okay.
Thank you.
So if you dilute more the histoacryl, if histoacryl is diluted at higher level, then the plug the whole plug may be pushed by the onyx.
Thank you, sir. Can I ask you a question?
Please.
Basically, for AVM study, what we are accustomed to study number of feeders, nidus, and venous morphology. But what I understood from your lecture today, if we can understand venous tributary also, that is very good tool to understand the nidus and segmental transvenous embolization. So can you guide us how can we increase our understanding in order to be oriented with more venous anatomy and ramifications?
So some answers may be too obvious, but I think that once you start to go through the vein, you look at the veins differently than before. When you need to see which vein you may access, you look at it much more than we used to do. Second point, doing rotational angiograms with 3D reconstruction is something which is very important. And to do so, looking at the MPR reconstructions, multiplanar reconstructions are very helpful. Some details, if you do so, inject early enough to have not only the artery, but all the veins during the whole rotation. This requires usually to have at least 40 ml of contrast. If you don't take enough contrast, you will just see the arteries and not the veins. If you look at the MPRs, to start to understand the AVM, you look at thick slices. The thick slices give you good images, but when you want to go into the details to know where each vein is joining which other vein, then you need to reduce progressively the thickness of the slices. So those points are really important to do the MPRs, to scroll through the MPRs in the 3 direction, and to progressively reduce the thickness to understand how the veins are connected. Last point, if you do the rotational angiograms with the MPRs, this has to be done before the first embolization, because the more you embolize, the more you create artifacts and the more you lose on the.
Thank you, sir, for your explanation.
Yeah. Maybe I have one more query. Can I ask, Dr. Chapot?
Please.
Yeah. So In this venous technique, you are reducing the BP to quite a low level, around 60 systolic. So, what are the anesthetic checkup? What you do, because of many of the cardiac patients where the cardiac compromise is there. So, is it a very good and safe way so that you can reduce the BP till 60, or you have some special consideration, or you go for arterial balloons to reduce the arterial pressure?
I enjoy a lot your questions because all your questions are very accurate, definitely. Indeed, it's a problem to reduce blood pressure, and it's a progressive workup to obtain those values. And if I go to places where I'm not usually, and when I ask for low blood pressure, it's a problem. And anesthesiologists are not happy me to ask so. Definitely. Interestingly, we did not have problems related to this. I mean, most of AVM patients are young patients. We have some elderly patients, but most are young and they don't do any efforts. So even if it's pointed from the point of view of the heart, that some decompensation could go there, it's more at the level of the kidneys, where the reduction in perfusion could be an issue, which did not happen. The duration of hypotension is also when you start to place coils in the vein. So if the procedure is a 5 hours procedure, 5 hours would be 4 hours to place all catheters in the arteries and the veins to understand everything. But then when you start to coil and to embolize, this is never more than 1 hour, usually 30 minutes, where the blood pressure is low enough. So the two problems we had were in children, where putting the blood pressure down induced some, I don't know how to say it in English, you know, the skin at the level of the feet was injured because of less perfusion at the level of the ankle. So in fact, minor problems.
Because of the sheath in the femoral artery?
No, because of the compression of the leg and the reduced blood pressure, so reduced perfusion at the foot.
Okay.
So we had two, but only two. So it's non-relevant.
Okay. And one case you had shown is the excellent one where you did embolization through the ACA, NCA, and PCA, and the peripheral crescent of the nidus was remaining, and you went through the vein and you just completed it. So for the large AVMs, do you suggest first to go for transarterial and then whatever is remaining go for the transvenous? Or initially you put both the catheters and try, embolizing?
Large AVMs are just like a Mikado games. A Mikado, you know, the sticks is Japanese sticks. Yeah. It's so complicated that it's impossible to understand. So you need to reduce, to turn it down more and more. So from the beginning, to go from a transvenous is absolutely not reasonable. So you reduce it as much as you can, and then suddenly you start to understand which are the remaining veins. That was what we did in this patient. But I would say it's a game with many components. So transarterial embolization is one way to do things. Surgery is a very good other way. But transvenous also. So we have situation where you can go through the vein to occlude the deep part. And once the deep part is occluded, this AVM becomes accessible to surgery. And if usually the problems are the same for each specialty, if we've got a chance to be able to downgrade difficult AVMs to less difficult AVMs because we occluded the the deep part, this would be a great advantage for a combined embolization and surgical strategy.
Yeah. And in your series, in how many cases, maybe it's maybe very few, but I'm just asking, how many cases you saw the patient bled on the table and you had to ask for neurosurgery help and they really could help you?
So on the table, I think it's 1. The number of patients that bled is 15 up to now. All did not need surgery, but I would say 10 required surgery. And in some patients, it was really a very good and important thing that surgery could help to remove the hematoma. And the bleeding is, there are no major vessels bleeding, but bleeding is an issue. So
Right.
I'm very thankful to my neurosurgical colleagues to have helped me in those situations.
Absolutely.
Thank you, sir.
Absolutely.
Thank you, sir.
I think Gaurav has joined. So
Yeah.
I'd like to hear some comments from Gaurav also. Hi, good
Yes,
evening,
Gaurav.
Gaurav.
Hi, Dr. Kalyan, how are you?
Yeah, I'm good.
Thank you,
Hey.
Dr. Rene. It was mesmerizing lecture. Like it's like seeing a magician doing things to the AVM.
Absolutely. That's what I told him.
Yeah. So I have one question for you. I think part of it, which you have already answered. What are the cases where you do not do transvenous these days? You look at the AVM and say, I will not do transvenous in this case.
It's reducing. It's reducing. Some situations when the artery is much more easier than the vein. I mean, navigation in the artery is usually much better than in the vein. So it's a very natural way to go through the arteries. By the way, if you go transvenous, usually you first have to go transarterial. So transvenous is on top of transarterial. But still the rate of transvenous is increasing, and I would say most AVMs today are treated first 1-2 times transarterial and then last time transvenous.
And like, do you still do that if it's a ruptured AVM? Like if the patient has bled, like do you do it now or do you stage it for a later date, the transvenous?
The underlying question is, should the AVM completely be cured? And it's not easy to cure completely ruptured AVM by embolization because some part may be compressed by the hematoma. So in a ruptured AVM, I don't think it's good to go on for curative transvenous from the beginning. You may do partial transvenous if this is the way to get access to the suspected part that bled, but finishing the AVM the same step is dangerous because you may compromise the remaining venous outflow. So better not to do it in one step.
And one very basic question, how do you access the vein? Like, do you do a direct puncture, direct stick in the neck, or you come through femoral?
No, always jugular access. Jugular access makes it much straightforward, much more straightforward.
And like once you have closed everything, like you are sure you have taken off the nidus, you have taken all the veins, are you worrying about the thrombosis of the vein? Do you give some anticoagulation once the patient wakes up, or you just let it be?
So it's a very interesting debate. The debate on anticoagulation after embolization of AVM, which is a quite recent debate. So now we discuss it more and more. I would say this is something what I do when I've been doing transarterial, and I fear to compromise some of the vein. Whenever I go through the vein, either it's for cure or it's for segmental transvenous, where I control one vein and I occlude the corresponding shunts. When doing so, I don't need anticoagulation because the vein is supposed to be controlled, which means the other veins are still patent. So after transarterial, yes. And I showed also one example where the outflow in the vein was significantly reduced after transarterial, but in transvenous, usually no.
Okay.
Do you have
And
any other questions, Prof?
one last thing, like you have a very small ruptured AVMs after your transvenous, I think 15 odd cases which you have seen. Is there any one thing you have observed, like why they have bled, any indicator of what went wrong in those cases?
It's frustrating from transvenous to find out the reason for bleeding. The reason for bleeding is, I think, better to be seen by arterial selective injections, where the more you look at each of the arterial feeders, the more you have chances to find a flow-related aneurysm that bled. But again, if there's a ruptured AVM, I try to avoid going on for a transvenous cure, because the compressed part of the AVM may bleed and may not be filled with embolic agent.
Sure.
Thank you so much. Thank you so much to answer all the questions.
Thank you, Gaurav. Thank you. Dr. Shomon, have you any question to Professor? Dr. Shomon, you want to ask something?
Yes, sir. Sir, I have a question to you, sir. Sometimes in a single session, we just cured the AVM, and sometimes we need multiple session. My question regarding what are the differences in these two scenarios regarding the NGO architecture of the AVM? Is there any difference in NGO architecture?
Yes, it's a very good point. There is a difference. If you want to go on stage venous, you must be sure that the length of vein you have is long enough to control the reflux. You see, it's a kind of V. If each vein is long enough to control the reflux, then you can cure it separately. If the veins are too short, that you cannot control reflux, and that you cannot create and don't have the place to do a plug, then you need to do both. But safety is always to go on for stage procedure. Whenever you have some vein which is still open, the AVM will not bleed. The AVM may bleed after a procedure only once you've been occluding the vein, and then you must be sure that all shunts are done. But how to be sure? The more there are shunts, the more it's difficult, the more it's dangerous. That's why if you're able to reduce progressively the number of shunts, and if what remains is a very limited amount of shunts, then you're safe. If you have a huge amount of shunts to occlude, then it's very dangerous.
Thank you, sir.
So I have a complementary question. In case there are multiple feeders from cortical arteries as well as perforators, in that case, what is your preferred option? Which one you take first? If he stays.
If you have multiple
Feeders from cortical arteries and lenticulostriate perforating arteries, which one stays? On that.
So first, reduction by cortical arteries. So you will reduce, the fear is always at some point you block the vein and you're not sure to get all the shunts. So whatever you can do on a quite safe way before should be done.
I have a very basic question for Dr. Rene. Yeah, how do you decide treating on a ruptured versus unruptured AVM?
And ruptured AVMs are usually clear indications. Unruptured AVMs are very debatable. Indications are changing.
Aruba, did it make any difference?
Yes and no. I discuss with my patients to mention the results of Aruba, because you cannot avoid mentioning those results that are for embolization. However, it does not solve the problem. So we're not in a hurry. If a patient does not want embolization, I think that the risk for him to come back at some point is very high. So this is what I tell to him. And I say also that in Aruba, there was no venous treatment.
True.
And venous treatment changed a lot the game. But I try to see whether the patient is symptomatic and what are these problems, including into symptoms, headaches. I'm surprised to see how much headaches are under-evaluated. I mean, headaches is too common to be really interesting, but some patients are strongly disabled because of headaches. Interestingly, if you do a partial arterial embolization, headaches are usually gone. So I'm not defending partial embolization, but for the quality of life of the patient, partial embolization is something which is also very helpful in this selected population. So are unruptured AVMs to be treated? In my opinion, yes. If you're fine, if you can see your data, what is the rate of complication that is to expected according to location and according to the all over situation, the age, the location, and the size of the AVM.
Right. So, so we know the AVM treatment of AVM has got a very clear indication of bleed, then seizure, which is intractable probably, and gradual neurological deficit. But in this context, I'm just asking a patient who has never bled, maybe occasional headache, only with seizure, late onset seizure, presented at 55 or 60 years, which you can control seizure with medicine. Will you contemplate embolization or just watch him if he doesn't have any weak point like intranidal aneurysm or those things?
I mean, watching is also certainly a way to proceed, and there is no hurry. You cannot predict when the patient is going to bleed and if he will. Interestingly, is the work which has been done by a Swedish colleague who is doing radiosurgery, Bengt Karlsson, and who looked at the rate of bleeding of AVMs on a different way. He did not do it retrospectively. He followed the charts of 3,500 patients with AVM, looking at the age of the first bleeding. This is now published, I think, in Journal of Neurosurgery, and he found that the bleeding rate per year is of 3.2%, and is not related to the fact whether the patient had a previous bleeding or not. So 3% is not figures that justifies any risk. So I leave it open to the patient, and some don't want any treatment. But as soon as symptoms come back, usually they start to struggle.
True, true. Yeah. Okay.
Sir,
Thank you very much. Thank you.
Sir. So I have a question regarding the ruptured AVM management. Usually, we used to embolize the ruptured patient after 3 to 4 weeks. This is the protocol. But 2 of our patients, possibly what I can remember, in this period of waiting, they become they rebled and become bad in clinical shape. So what should be the management protocol of this ruptured AVM? Should we wait or should we do something for that, those patients?
Thank you to share your experience. It shows that no rule is perfect. The reason not to treat AVMs at the acute stage is that the risk of re-rupture is considered to be very low, but you show that it's not as low as expected. The other reason was that historically, the catheters that were used for embolization were only flow-guided catheters without any wire. So without any wire, having an AVM that creates a hematoma and mass effect makes navigation of the catheter very difficult. If you have a wire that enables to support navigation with the catheter, you can access to the feeders. So usually, I'm not sure that waiting is the best way, and at least doing a super selective injection of all the different arteries to check, to look for a potential aneurysm is a help that quite often enables to see where is the underlying arterial lesion.
Yes, sir.
Thank you, sir.
So it has been more than 90 minutes has been passed. So can we stop now, or we can pass 5 or 10 minutes? How do you feel? Do you allow us
No, it's
5 or
fine.
10 minutes?
It's fine for me. It's perfect.
No, thank
It's
you.
good.
We have few Bangladeshi faculties with us. We have Brigadier Said Jahirul Alam, who is head of Interventional Radiology Combined Military Hospital. Brigadier Jahirul Alam, you want to ask some questions to Professor Rene?
Hello, good evening,
Hello.
Dr. Rene.
Hello.
Hello.
Nice to meet you.
Yeah, uh, I want to share one of my experience with you. One young patient, a lady, she has a very big AVM outside, I think, posterior to parotid region near to occipital, and it has some intracranial component is also there. It's a huge AVM. So, what do you suggest? Basic question is, what do you suggest? How many sessions you may consider, and what are the things you may use for that large AVM? Should we go for onyx, glue, or coil with glue?
So superficial AVMs have some specific characteristics with regard to intracranial AVM. Some of them being that usually it is difficult from arterial embolization to reach the veins. And a lot of embolizations are quite proximal, so not so helpful. So definitely if you go on through arterial embolization, it's important to use an arterial pressure cooker, take 2 catheters, put histoacryl in the more proximal, so through the distal you can inject onyx.
Okay.
But then you must be prepared to have potential that create functional and aesthetic impairments. The second problem with the superficial AVMs is that they are likely to further grow, especially if the woman is pregnant. When there are hormonal changes, the AVM will continue to grow. So there are different primarily preliminary works showing that taking some medication can help to this AVM avoid to grow. So certainly it would be helpful to give her some rapamine. Some rapamycin is something that avoids neoangiogenesis. So I would strongly recommend to do so.
Yes, sir.
So, in that case, you were suggesting we may go for multiple sessions because
Anyway,
Thank you, sir.
and usually it must be combined to surgery because the vessels are large, are obvious, but when you treat them, you will fill those vessels. So they need to be operated. So you need to find the good way I mean, to have a plan that you discuss with the ENT surgeon working with you. It must be a combined embolization and surgical treatment. But first, extensive embolization. And once both embolization and surgery are done, then she should take some anti-angiogenic medication.
Okay, thank you. Thank you, Ren.
Thank you, sir. Professor Sharif is Professor of Interventional Neurology. You want to add something?
Thank you,
Maybe
Shofik.
one of the
Can you,
last comment from
Shofik, can you
please.
hear me?
Yeah.
Professor Rene, thank you very much. It was an excellent lecture, and we came to know a new concept of transvenous embolizations. So I have got a very two basic questions. While we are going to treating any aneurysm, if we understand the angio architecture, we go through global injection followed by sometimes super selective injection to know the morphology of the nidus and vessels. But if we go through venous approach, how to do the super selective injection and to understand the morphology, number one. Number two question is, all the AVM catheters are prepared, it is flow directed catheters. That means it flows in directions and anterograde flow in the artery, but in retrograde flow in the venous, how you manipulate this kind of catheters in microcatheter reaching the target?
So definitely one problem of transvenous is that you cannot inject through the catheter to see where you're going to. This requires first to have an all-over understanding of the AVM. And for this, you need to look at the MPRs and at the 3D reconstruction of the AVM, point one. And point two, when you inject selectively each of the different arterial feeders, you must look at the veins, which means you must do the injection of the selective arterial feeders in the same working projection.
So in that case, if I inject an arterial route, I have to follow the venous route, isn't it? Is it not taking much time once to know the angio architecture, once injecting in the arterial, then again taking the plan of transvenous embolization? Is it time taking matter?
No. I think audio is disturbing, Sharif. We cannot
Okay.
hear him properly.
No, my question is, once I am understanding the angio architecture through the arterial route by feeder super selective injection, and I have to follow the venous drainage also. And finally, when I plan to go for transvenous, then I have to again follow that transvenous
I
route.
think Professor is disconnected, Sharif. I think he's disconnected. Let's wait for him to come. So we got a brief of disconnection.
Okay.
Do you hear us?
Yes.
So I think it's been a long time. Zuckerland, you have any points to know, or we?
I think yeah. Because I think Dr. Rene is got no for some reason.
Yeah.
Okay. So do you have any other questions, or everything has been answered?
No, I think it's all. I think once again from CNW family, we'd like to thank you very much for your wonderful time and wonderful lecture. We learned a lot. Really, we learned a lot. We enjoyed every moment of your talk. I think me, including our younger colleagues, learned a lot regarding your transvenous and pressure cooker technique. And we'll be looking forward to hearing from you again and again. Thank you very much for your time. Thank you very much.
Thank you, Shofik, for a nice arrangement. And thank you, our panelists, Professor Gaurav and Professor Prabhakar. We are very happy to enjoy this session. Thank you, Shafiq.
Thank you, sir.
Okay.
So let's put our hands together and give big claps to them. Thank you, sir.
Good night to all.
So thank you, sir.
Thank you.
Thank you, sir. Thank you.
Thank you. Bye-bye.
Thank you very much. We'll try to get connected with you at any time, any point. Thank you. Thank you, sir.
Okay. Thank you. Thank you.
Thank you, Shukarlan. Thank you, Gaurav. Thank you very much. Thank you, everybody.
Thank you, sir. Thank you. Thank you.